Morning, Monday again. Can you believe it? Hopefully, everybody had a good weekend. We are back, and yeah, we're moving on from just this. Oh, can't see that very well. Hold on, let me just sort that out. Just get that. So some bits of it are still a bit weird. Oh, let me just see if I can sort that out. Wrong way. There we go. That's better. So yeah, we're going to build on this. So we started to go over all of the different bits of the lumbar vertebra, and we're going to start to add some layers on now. And just messing around there, I've just got rid of one of my screens. There we go. Cool. Yeah. So we're going to do a bit of a recap around the bony anatomy, and then we'll start adding some of the passive structures on, mainly focusing on the ligaments today, and then I'll include some of the fascia when we look at the muscles because they kind of come in together. Morning, Sarah. Good morning, Neil. Got a few in this morning already. Yeah, cool, good. Um, Here he is. Happy Anata Monday, mate. There's going to be an exclusive this week, and yeah, so, maybe we should sort out some commission for you. I don't know, but there will be. I've actually had requests for some merchandise, so I've been meaning to do it for ages, and amongst all the other things that are going on. And it's nearly ready. So hopefully it will be done this week. So we've got, in fact, just give you a bit of an update actually. So Sarah, who was just on there she is. Brilliant help last week. And because we are putting together a mentor program, and I know a few of you have expressed an interest in that already, and I keep on saying, "Oh, it's nearly done. It's nearly done." It should be done this week. So hopefully that will be launched this week. So thank you, Sarah, for your help. And you will be one of the mentors as well. So I'm sure that people will want to link up with you as well. So yeah, depending on where the mentor is, will depend on what they do. So, because I've got my clinic in Birmingham, there'll be an option to shadow me in clinic for the day, as well as doing Zoom sessions one to one. So yeah, we're putting together some like 6 month mentor packages for people. So if you are interested in that, then give us a shout. I'll pop out some details in the group a little bit later on in the week. For those mentors that don't have a clinic, they're available on Zoom, so you can have one-to-ones on Zoom with them and talk about. Well, it depends on what their expertise is, really. Building your business or tricky patients or whatever it is. So. Yeah, so really excited about that happening. It's an idea that came up with in January, and yeah, again, it's just I wanted to do it really well. So and I wanted everything to run really smoothly for both the mentors and the mentees. So yeah, that's pretty much ready to go. So that's good. And then yeah, the clothing and that. I can't remember who asked for it. I think it might have been Sharon, who's in the group as well. Yeah, so Sharon was asking about, I think it was a hoodie or something. So yeah, we're going to get those going as well. Yeah, exactly. Yeah, it has to be done. Oh, I've missed you off there, Stevie. Good morning, Stevie. Morning. Morning, Becky. You've got the usual crew in. Good. Cool. So yeah, if you've done anatomy before to any kind of depth, then this might be a bit of a recap session for you. May not be much new, but I think with all of these things, you kind of the more you go over it, the more you realise, oh, I've forgotten about that. So hopefully for you guys, this is one of those sessions. For those of you that don't have a clue about any of the ligaments in the spine, then you will by the end of today. So here we go. So a little bit of a recap first. Just going to move me over there. Yeah, I wanted to go through this because this is the whole reason for doing this kind of thing. Is just sort that out. There we go. Is to get you guys used to reading things like this. So this is just one that I picked up off the internet. This is a typical MRI report, and you may be brought this by your client or your patient, and they're going, "No one's explained it to me," and this is usually the case, and it sounds really horrible what has happened, and the kind of things that they're describing. So hopefully by the end of, well, from from last week, you should understand what some of these things mean. So if we just go through just the basics of this, and then we can have a look. We'll do a bit of a recap, and then we'll have a look at it again. So these down the left hand side here, these are the levels of the spine that are that have been examined. So when you request an MRI report, the radiographer will only scan the bit that you ask for. Okay, so you don't assume that they're going to do extra bits and have a consultation with them or anything like that. And obviously it depends whether they go private or NHS. If they go NHS, then they usually have to go through their doctor. But you can pay for private scans. They're round me. They're about 220 quid, I think, for an MRI. And I can write a report or a request, and then the radiographer will do the imaging, and then I'll get a report like this back, and then we make a decision on what to do based on that information. So these are the levels of the spine. So obviously T12 L1, so that's thoracic vertebra number 12 to L1, between L1 and L2, L2 3, L3 4, and L4 5. So that's standard what would be on an MRI report. And then basically what they do is they're only looking at the image, and they will give you a kind of black and white view of what is going on with that person's spine. So obviously we're looking at the lumbar spine at the moment. So this terminology will be really useful for you. So some of the things to look out for. So no central spinal canal or neural foraminal stenosis. So if you've never heard of the word stenosis before, it basically just means a narrowing. So and that some of these when you Google stenosis and you look at the images of a stenotic spine, then it will scare the bejesus out of you. So if you haven't had this explained to you, and you're told that there is spinal stenosis, then you will think that something really, really bad has happened. Okay, so we need to be really careful with the way that we explain these reports, because it literally is. It's just a picture. It's like someone doing a postural analysis. It's literally a snapshot in time. So you have to take into consideration so many other things other than just the imaging. And I'll show you something in a second just to confirm that as well. So between L1 and L2, there's no central spinal canal stenosis. So there's no narrowing in the spinal canal, which we would on the previous session. That was the vertebral foramen. So that's the central part where the spinal cord will go through. No neural foraminal stenosis. So the neural foramina is often called the vertebral what do you call it? Like transverse foramen or intervertebral foramen. So it's the ones on the outside of the joints. So these bits in here where the nerves come through. Okay, so it's saying that there's no neural foraminal stenosis. So there's no narrowing of that area, basically. And then minimal disc bulge between L2, L3. Okay, that sounds good. Mild facet arthropathy. So hopefully you understand what a facet is now after last week. So these are the joints at the bottom and the top of the vertebra where they interconnect to each other. And if you remember last week, we were talking about the range of motion available in those joints. And in the lumbar spine, the range of motion into rotation is quite limited, but into flexion and extension, it's really good. And that is because of the orientation of those joints. So they're like side by side, like this. So they can't rotate because they kind of bang into each other, but they can glide up and down across each other. So you're able to flex and extend through the lumbar spine really well, but rotation through the lumbars is not so good. Okay, it's just the way it is. And there's a mild facet arthropathy. So basically, there's something in the joint. Okay, and we'll talk about that in a sec. No central spinal canal stenosis, so that there's no narrowing at that level, and no neural foraminal stenosis either, so that's good at that level. Then L3, L4, a trace retrolithesis. Okay, so a lithesis, easy for me to say, is a sliding of the vertebra. So if you have one vertebra and then another one underneath, a lithesis is a movement of that vertebra. But this is so this is talking about a slight lithesis, but there's a minimal disc bulge there as well. Okay, so we've got a little bit of a backward slippage and a minimal disc bulge. So retro just means back. Well, think about retro discos. Yay! So retro is going backwards. Lithesis is a slippage. Then we've got minimal disc bulge, mild facet arthropathy. So we've got changes to that facet joint, no central spinal canal stenosis, and there's a mild inferior foraminal narrowing bilaterally. So mild, so it's not so bad. Inferior, the lower part. Foraminal narrowing. So there's I don't know why they've used narrowing here and stenosis everywhere else. That's that this is a thing with reports. Sometimes the language can be confusing. And then bilaterally, both sides. Okay, so for some reason something is sticking out both sides, but maybe to do with this disc bulge. And then L4-5, there is a 1.5 millimeter. So if you get a ruler and have a look at how much 1.5 millimeters is, it's not a lot. Okay, circumferential disc bulge. So going around the circumference. Mild facet arthropathy, so mild changes to the facet joint, and no central spinal canal stenosis. So again, no narrowing of that canal. So this would, I don't know, because you've got to be careful again. It wouldn't say that this is a bad MRI, okay, because things they look okay. Yeah, but you might, as a layperson, pick up some of these words, not really understand what they mean, Google them, and it will scare the bejesus out of you. So and then you'd be just worried about moving your back just in case something's going to happen. So if you just Google some of these terms after this session, so arthropathy, retrolithesis, what else is on there that would be interesting? Yeah, circumferential disc bulge. If you search, because that's what you would do as a layperson, you would Google those things, and without a full context, it may really, really worry you. So let's just put your mind at ease. This is a really, really good paper. I show this a lot to my patients. Well, a summary of a paper. So this is a literature review of imaging features of spinal degeneration. I don't really like that word, but spinal changes in asymptomatic population. So people with no discomfort. Okay, so they had no pain, but they had an MRI done. These are the ages along the top. Okay, so you can see from the 20s up to the 80s. And then these are the kind of things that you would see on an asymptomatic person's imaging. So for a 20-year-old, 37% of the 20-year-olds that were examined had disc degeneration. Okay, so nearly half of 20-year-olds. So when you look back now at that previous MRI, where we see, go back, so disc degeneration, oh, wrong way, here we go. These mild disc bulges, minimal disc bulge, those are normal findings. I mean, obviously we don't know how old this person is, but these are normal findings. Okay, it's a normal thing. So let's have a look. There we go. So disc bulge, 30%, 40% in your 30s, half of 40-year-olds. So I've got disc bulge, definitely. Okay, pretty much. 50-year-olds, 60%. So you can see as you get older, these things change, and that is entirely normal. This is the facet arthropathy. So if I just come down here, and again, this is where it gets a bit confusing because of the difference in terminology. So facet arthropathy, which was on the report facet degeneration in this systematic review. So you got 4% for 20s, 10%, 18%, 32%. So again, depending on the age of that person, these are usual kind of findings. And then we've got a spondylolisthesis. Okay, and again, we've got the figures for that. So just because they have these changes, yeah, all of those things listed here, these people were asymptomatic. They had no problems at all. All right, so it's really worth making sure that we show people this. Okay, so as a good question, the age of the person is very relevant. The age of the person is very relevant in this. Yes, it is. Yeah, because obviously as you age, things change. So and we always used to associate it with kind of things getting worse, but actually it's just normal aging. Yeah, it's like hair going grey. It's like wrinkles in your skin. We don't we you don't well, it depends. You might have stuff done for wrinkles in your skin. It depends on what you want. But yeah, you don't look at those normal signs of aging and go, oh my god, there's something wrong with you. Those are just normal things that happen, and these are normal things that happen on the inside. So I often will say to people that these are like wrinkles on the inside. Okay, so and people usually get that. Less back pain after 60s, and that's usually because of this going on. So we've got less mobility. It doesn't move as much. Okay, so you will be more restricted as you get older because of the different the changes in the facet joints. You get those arthropathies as you get older, and because there's little bits of bony growth coming off of them, then it just means that you don't move as well. Okay, so it's in general, but it depends, because if you I posted something today about knees and hip OA, osteoarthritis, and if you're sedentary, then these kind of degenerative changes are quite prevalent. And if you're very active, like elite competitive active, then they're very prevalent as well. But if you're moderately active, then actually that's protective. So if you're moderately active throughout your life, then that kind of lifestyle is protective against these kind of changes. Okay, so it is quite interesting. Just see if I've missed anything. Just scroll through. Yeah. Oh, Helen's in. Hi, Helen. Morning. Hopefully be worth it. Cool. So hopefully that just kind of puts things in a bit of context, really. So the reason why we're learning about lumbar spine anatomy is because of this, that this will really help you communicate with your patients. But don't worry, because of this, it is quite normal. Okay, cool. Right then, just some words then that should hopefully be in your mind already after last week. So we had a look in detail at the lumbar spine, and we looked at all the different sections of the lumbar spine, and these were some of the words that came out. So lamina, if you remember, we were talking about sheets of bone. So we've got like laminate flooring, like sheets of flooring, and that's basically what the lamina is. And they come off of the pedicles, which are the little feet. So these little bits in here and here. It's a real issue with kind of glare on the screen today. Let me just see if we can get that sorted. Ooh, wrong way. Oh, wrong way. I think that's about as good as we're going to get it. Cool. And there, yeah, so pedicles with the little feet coming off of the body. So that's the body there. And then you've got these little bits coming off here and here. And then the lamina then came off of the pedicles and wrapped all the way around to form that neural arch. So that's the posterior aspect of the vertebral canal, which is where your spinal cord will go through. Okay, so that's all that bit there. This will become important in a sec. Then we had facet joints, so the little faces These are the joins above and below that connect to the next vertebra above, okay, or below, depending on which direction it's going, and they're very smooth. Okay, so that's why they're called facets. They're also called zygapophyseal joints. Okay, so a big name, but generally they're called facets now. So superior above, inferior below. Is an articulated lorry, if you didn't know what that was. So one that joins, basically. So it's got a joint in it. And that's what articular means. So anything with articular means a join. And then foramen or foraminal is an opening. Okay, so those are the key words from last week. Something else to hopefully make you not so concerned about back pain. If we have a look here, these are the usual categories for why someone would get back pain. Okay, so we've got visceral disease. So this is to do with something in your guts. So some kind of pelvic organ, prostatitis. What else have we got? Inflammatory diseases. Let's have a look. Aortic aneurysm. So we talked about that before. So these are really rare. These are 2% of all back pain cases. This was back in 2001, a paper called Lower Back Pain. So you can have a look for that reference there. Non-mechanical spinal conditions is 1%. Okay, so these are, so neoplasia is like cancerous growth. Okay, osteomyelitis, so you've got some kind of inflammatory disease of the bones or the muscles. What else have we got? Shingles, ankylosing spondylitis, so that like rheumatoid conditions. These are 1%. Okay, the other 97% are usual mechanical lower back pain or leg pain issues. Okay, so and then if you have a look at the breakdown of all of those, the horrible ones, congenital diseases, traumatic fractures, these are very low. Spondylolisthesis, so that's slippage of the vertebra, these are really low too. What we're more likely to see are these: lumbar strain or sprain, idiopathic pain, which is a posh way of saying we haven't got a clue what it is, and no pathoanatomic conformation. So basically, there is nothing structurally wrong. Okay, so that's good, because most of the things that we see, 70% of all back pain, we haven't got a clue what causes it. And it's unlikely to be life-threatening. So basically, we just get people moving. So that's really comforting. I think is that most of the things we see we can actually deal with. Okay. Right, I just missed a few questions. So, can facet joints become locked? They can. They can if you're older, and they've got osteophytes, which are the little bony growths coming off of them, because that will close up the space in between the joints. So then it will make it a bit more restricted. In terms of kind of locking, which I usually hear, that's usually a muscle spasm problem. So there's been an irritation of the joint for whatever reason, and then the muscles go into spasm to protect the area, and that's probably what you would see more of. Okay, so good. I think hopefully that answers the question. There's another one here. So Penny, interested to know what people's views are on moderate activity for guidance, general medical officers guidance, but assume it depends on the person and increase their abilities slowly. Yeah, exactly. I think what I tend to do with that is go, right, okay, where you need a benchmark. Where are you now? Where do you want to be? And then what's the gap in the middle? And then whatever the gap in the middle is, the goal might need to be changed because it's unrealistic, or the time frame lengthened to make it more realistic. And it's only then, when you've tested what they can do and where they want to go to, that you can build a program to get them where they want to be. Okay, so and it's got to be individual, definitely. Do you know what? There is a there is a catchphrase for a T-shirt right there. Okay. Yeah, perfect. Cool. So hopefully this table, and have a look at this this paper. I'm pretty sure it's easy to get, so you can have a look at that. But this kind of should fill you with a bit of confidence, because we're going, well, most of the stuff we deal with, 7 out of 10 people, there's nothing really wrong. Okay. Yeah, good. Yeah, that's a good shout, actually. Yeah, so Chris Tiley, Never Toiled to Lift, good reference for that. Yeah, definitely. He's just been upgrading all of his YouTube videos, actually. Yeah, and that's so Chris works in my clinic, and he's part of the mental program as well. So if you want to go and observe him in clinic, and the kind of thing he does with getting the sort of over 60s, over 70s, in their 80s, and even 90s lifting weights. Okay, so it's how you do it. Good, perfect. Right, a little bit of a recap then. Just move me up there. So we've got so obviously we're focusing on this part of the spine. We'll just get rid of that. So we looked at the vertebral body, the back of the vertebral body. So this forms the front of the neural arch. Just move me up there. This is the back of the vertebral foramen. So that's the front of the vertebral foramen. This is the neural arch. Okay, and that's the back of the vertebral foramen just there. There's your spinous process. That's the bit you can feel at the back. And then the transverse processes. It depends on the person, but usually you can feel the transverse processes in the lumbar spine. This bit here is called the lamina. That tiny bit there, the little feet off the end, those are the pedicles. Okay, so that's a bit of a recap from last week. This is a bit of a recap as well. So in the lumbar spine, they've got short horizontal spinous processes. So these bits at the back, they're not as long as the transverse processes of the spinous processes of the thoracics or the cervicals. Okay, so they're a different shape. They're a lot flatter, a lot bigger. It's got a larger vertebral body because of the weight going through it, so they develop bigger to withstand that load. They've got large, thick facet joints, which are the articulations above and below. Okay, and the vertebral facets are at 90 degrees in the sagittal plane, so they're at 90 degrees in this plane, which means that they're very good at going forward and back, not so good at rotating or side bending. Okay, so most of your flexion and extension from that region of your back, so the kind of lumbars and thoracics, will come from the lumbar spine. Okay, that's what's normal. So if you notice someone doesn't rotate very well through their lumbars, that's because you don't. Okay, there's about 1 or 2 degrees of rotation through the lumbars. So if you think about that at each level, you're going to get 10 degrees pretty much of rotation through that lumbar spine. Okay, so it's not much at all. Cool. So yeah, just going back to this, hopefully doing a bit of a recap of those and going over those will help make some of these make a bit more sense. Cool. This we're going to cover a little bit more, well, a lot more, when we get to the nervous system and we get to the lumbar plexus. So we did the sacral plexus before. We're going to move into the lumbar plexus. But this is useful to know because of where it passes through. Okay, so this is your spinal cord, and we talked about this a little bit last week. So your spinal cord finishes at the level of L1, L2. So that's where it stops. Okay, but people often think that the spinal cord goes all the way down to the coccyx, but it doesn't. The cord, the end of it is called the conus, and that ends at around about L1, L2. Okay, the rest of it is called the cauda equina, and when we look at the nerves, we'll cover that in a lot more detail. At the end of the cord, there is a really long ligament. So the ligamentum or filum terminale, and this attaches into the coccyx. And basically what it is an anchor for the spinal cord. So if that wasn't there, then the spinal cord would come up into the spinal column. Okay, so this keeps it in place so that it's not just floating around. Okay, so that's just something interesting to know, and we'll see this in a bit more detail when we cover the nerves. Cool. Now this is a really, really good book. This is how I made a lot of anatomy make sense for me, especially the shoulder, where you've got loads of different things going on in the shoulder. This is a book, I'll put a link in the group afterwards, by a guy called Kapanji. And what he does is he kind of separates everything out, and he layers the muscles on. And when he layers the muscles on, he shows the direction that they go in and the magnitude of the force. So if they're only a small muscle, they get a little arrow. If it's a big muscle, they get a big arrow. So you can see where the main actions of all the muscles are and which direction they go in. And it helps you just think about everything in 3D. Okay, so if we have a look here, there's your vertebral body. This will be your the arch, okay, which is made up of this little bit here, which is a pedicle, and then this bit here, which will be the lamina. Okay, so that if all of that is the arch, but when you split it in front of these bits, so these black bits here, those are the facet joints above and below. Okay, the pars interarticularis will be in between those, so the part in between the joints, which we talked about last week. So you've got pedicles, facet joint above, facet joint below, lamina around the back, spinous process sticking out a bit at the back, and then transverse process. Ooh, try not to move that. There we go. Move that instead. Transverse process just there. Okay, so side sticky out bit and back sticky out bit. Okay, so that's Kapanji. Like I say, I'll give you a link in the group afterwards. So now we've done a bit of a recap of the bones, we're going to have a look at where the ligaments go. Okay, so the first one we're going to have a look at is something called the ligamentum flavum. And basically that means yellow ligament. And you'll see why when we have a look at the video. So just want to give you a bit of an orientation of where things are. So if we have a look at this image here, there is your vertebral body. Okay, that is a transverse process there, and then that's the spinous process just there. So that area there is the lamina. So the bit we're going to be looking at, you're going to chop through that pedicle. Okay, so you basically chopping off the vertebral body, taking that away, and then looking at the back. So if you have a look at the direction of that arrow, we're looking in that direction. So what you can see in this image here is that bit there. Okay, so it's all that posterior aspect of the vertebral canal. Yeah, so here we've got the lamina. So that's the back bit. So this bit here. Okay, that's the bit we're looking at. That's the pedicles just been cut just there. So you can see that pedicle cut. That's your transverse process. So behind this lamina will be the spinous process. So we're kind of looking inside the vertebra. And then joining each one, so joining each lamina to lamina, is this ligament called the ligamentum flavum. And this is an important one because it's often one that gets mentioned on MRI reports. So if you are involved in an accident and you get kind of like shunted forward, what will happen is the vertebra will go into hyperflexion, which will stretch these ligaments and then may cause ligamentum hypertrophy, which basically means the ligament gets bigger, right? So if this ligament is getting bigger on the back here, it will start to fill the vertebral canal. So it may impact the spinal cord. Okay, so that's the important there. So Al's just asked, is there a condition where the ligamentum terminale can get damaged if there is an injury to the coccyx? Yep. Yeah, so if you fracture your coccyx, land on your bum, everybody thinks it's a bit funny, but it can be really, really painful, because if you fracture that bit, injure that filum terminale, ligamentum terminale, then it can cause some real distress. I've heard it being explained a bit like meningitis. okay, because of what happens to the spinal cord, because all of each level would be really, really sore. Yeah. Thank you, Sarah. Yep, is The Physiology of Joints by Kapanji. Yeah, and there are 3 volumes to it. Yeah, they're all really, really good. Cool. Right, let's have a look at those. So ligamentum flavum first. It's that one, hopefully. Yep, here we go. Cool. So I've popped up a picture here just to keep this in mind whilst you're watching the video. Okay, so hopefully I'll keep on referring to the 2. So if I just orientate you around this first. So these are the vertebral bodies and the discs in between. So you can see they've been cut down the middle here. So disc, body, disc, body. So we're looking basically at the side of a vertebra on this image. There's your pedicle, and then the lamina, and then that's the spinous process at the back. So what we're looking at is this bit here, which is the ligament in between one lamina and then the other one above it. Okay, so then if we go to the video, hopefully that will make a bit of sense. If the video, oh, it's doing it again. Bear with me a sec. Just find that video. Bear with me a second to just load this up. Ligamentum flavum. Okay, let's try that again. Get rid of that one. Bear with me a second. Sorry, guys. Just sorting out the layers of this. Why isn't that working? This is all going to go funny now, isn't it? Oh, here we go. Hallelujah. Right, okay, cool. Hopefully this is the one. Yeah, there we go. Okay, cool. Right, let me just show you this. I'm just going to take it back a little bit there. Okay, cool. So top-down view. So there's your vertebral body, just there. There's the vertebral canal. These are the pedicles either side, transverse processes, spinous process at the back. So the vertebral foramen is here. So that's where your spinal cord will go through. Okay, so let's have a look at that. So that line there is a line down the pedicles. Okay, so vertebral body, vertebral disc, pedicles down the side, just there. So they're going to cut down those pedicles. There we go. And then you're going to flip it around. And this was the image that we had on the last slide. Okay, so there's the end of the pedicle, end of the pedicle, end of the pedicle. Okay, there's the lamina. That's a transverse process. So we're looking basically on the inside of the vertebra towards the back, and you can see the spinous processes as you look through. And that is the ligamentum flavum. So it's the yellow ligament. Yeah, it just looks like a off yellow. So that's the lamina just there. There's the pedicles. So I've labelled them up there. So you can see where the lamina the ligamentum flavum attaches to that lamina. Okay, so one there, one above it, and then the ligamentum flavum either side. Yeah. So you can see it there and there, all the way down. And that will run the whole length of the spine. And then, yeah, so that bit there, so there's a pedicle, there's another one. So the one pedicle at the top and the one at the bottom, that will form the intervertebral foramen. So obviously if the vertebral body was still there would be that archway and hole where the nerves will come out. Okay, so the nerves will come out here, this side, that side, just there, that side through there. So you can see if there's a hypertrophy, an increase in growth of this ligament around that region, then there's a chance that it may impinge on a nerve root or the cord itself, depending on where it is. But that can be normal as well. Okay, so that's your first one. Hopefully this will go back. Yeah, so hopefully that will make sense with this. Yeah, so this is the image that we've just literally just seen. So pedicle, lamina, and then you've got the ligamentum flavum in between the two. Yeah, so that will hopefully makes that make a bit more sense. Right, now this one is a little bit more busy. So this was the image that we saw on the video, okay, and that obviously close up, so you can see some of the writing as well. So what we're going to do now is have a look at 3 more ligaments, so 3 more to look at. So vertebral body, 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 body. Okay, so these ones are full at the top. These ones here have been cut through, so they're basically sliced halfway. So you can see at the top there, that's the view that we're looking at, is that kind of side-on view. So you can see the honeycomb kind of makeup of that spongy bone in the middle. And we talked about this before, about the cortical bone on the outside, and then the spongy bone in the middle. And that's where the disc gets its hydration from. Okay, it's where it gets its nutrients from, because it's able to draw fluid from the center of the vertebral body. So there's your disc, there's your body, and then this one here, this is, in fact, there's 4 more ligaments. So this ligament here at the front, this is the anterior longitudinal ligament, and we did look at this briefly in the sacrum, because it does go all the way down to the sacrum as well. But this is a good image for the lumbar spine. So there is a ligament that goes all the way down the front. So let's have a look at that one. I'm going to see if I can switch it back to this. Hopefully. Nope, not playing ball. Okay, let's just go this one. Bear with me a second. Now got the spinning wheel of doom. That's never good, is it? Bear with me a second. In fact, well, you can kind of see it on that one anyway. Let me just run that. Oh yeah, it's not like in this at all. Okay, so I don't think I can control anything now. Oh dear. Hopefully you can still all hear me. Right, here we go. Cool. Right, let's. Here we go. Here we go. Cool. Are we there? Yeah, cool. Right then. So this is the front of your spine. Okay, so you've got vertebral bodies there and there. So in between is the disc. This was the image that we saw on the PowerPoint just a second ago. Those are the transverse processes at the side. So we're basically looking at the front of the vertebra. Okay, so let's just play this video through. So that white stuff all over the front there, that is your anterior longitudinal ligament. Okay. Yep, can still, cool. Thanks, Becky. Brilliant. So there's the anterior longitudinal ligament just there, and here it is cut away. Now this is an amazing dissection, this. So you can see the disc, vertebral body is there, that bit there, disc there, vertebral body there, and you can see how it covers all the front. So it attaches into the discs and the vertebral body of all of your vertebra. Okay, right from the top of your neck all the way down to the coccyx. Okay, so covers the whole thing. So if I'm going to just relate that to this image, so there's the anterior longitudinal ligament there, and on this image, I was thinking about flipping this image so it's the same orientation, but then all the writing will be backwards. So I thought it'd be better just to leave it like this. So there's the anterior longitudinal. Okay, so that's what it looks like in the books. That's what it looks like in real life. Okay. Just seeing your question come in there, Stevie. I'll get to that in a sec. Cool. So if you look at where it goes and it covering all the front of that vertebra, it's going to limit you going into hyper extension. Okay, so that ligament will help provide some integrity to that part of your spine. Cool. Let's have a look. So I know we can never assume, but it seems unlikely we would damage the terminale without damage to the anterior or posterior. Do you mean the ligaments, anterior, posterior, longitudinal? If that's the case, then yeah, probably. Yeah, you'd have to have a hell of a whack, I think, to injure that. cause some problems there. Yeah. Cool. Right, let's go back to this one. So, well, what have we done so far? So we've done this one, anterior longitudinal. Okay, we've done this one, the ligamentum flavum, which is in between each of the lamina. We're now going to have a look at this one, which runs down the back. Okay, so vertebral body, this is on the back of the vertebral body. So posterior longitudinal ligament. Here we go. Let's just, I'm not going to even try doing it the other way. Let's bear with me a second while the video just loads up. God knows how many gig of anatomy videos I've got on this laptop. So whilst that's loading, the interesting thing with the posterior longitudinal ligament, obviously it's very similar to the anterior. It goes all the way up or all the way down the vertebral column, but that there is a central piece to it. Okay, so oh come on, very annoying. So that central piece attaches to the discs. Okay, so you've got a really, really thick ligament that runs all the way down the back of the vertebral bodies and covers all of the discs at the back. So if you were to have a disc bulge coming out the back, then it's very unlikely to see. Oh, is that going? Is that going to let me choose a file? No. Okay, bear with me a second. It's still loading. Oh, here we go. Yeah, it's very unlikely to bulge centrally. All right. Let's get rid of that and that. Here we go. Sorry it's taking so long. Everything is all queued up, but as soon as you go live, things go wrong. Okay, so there's your vertebral body. Transverse processes either side, spinous process at the back. We've got a line down the pedicles again, so similar cut to before, but this time we're looking at the back of the vertebral bodies. Okay, so if I relate this to the image up here, so there's your vertebral body, we're looking at that line there. Okay, so the back of that. So this is the anterior part of the vertebral canal. Okay, so disc, vertebral body, disc, vertebral body. Those are the ends of the pedicles just there. So hopefully now all that terminology makes sense. And there is your posterior longitudinal ligament. So it goes all the way down the back of your spine, and it's really thick in the middle part of the disc. And this is what I was saying before. So if you have a disc bulge, then it's very unlikely to come through that posterior longitudinal ligament. It's more likely to go to the sides, because if there's any kind of material that comes out the back, it's going to be blocked by that posterior longitudinal and then diverted to the sides. So it will come out here or here. And this is one of the reasons we think why we have a posterior lateral bulge. Okay, so basically it comes out the side and so backwards and side, and that's because of this. And it kind of makes sense because this is protecting your spinal cord. So that makes sense. So rather than the spinal cord be affected, we'll just affect one of the nerve roots. That's what some of the thinking behind why that has developed the way it has. So these attach to the disc at each of the levels, and you can see it's like a barrier basically. There's your vertebral bodies, and that's that. Cool. Okay, so that's the posterior longitudinal ligament. So if we go back to the thingy again, just get the right one. I think it's that one. No, there we go. It is this one, just here. Okay, so that's all the way up and down there. Cool. And then the last one's nearly done. This one here and this one here, and they're both on the same video. So hopefully this might play. Please play. It's looking promising. No, It's just taking ages. Sorry, guys. In fact, I'll just keep that image there because I can talk you through it rather than trying to play it. Yes, exactly, Penny. Yeah, so this will limit hyperflexion. Yeah, good. As will these. Okay, so we've got this one here and this one here. So there's a vertebral body. There's your transverse process. There's a disc in between, transverse process. This bit here, that's your spinous process sticking out the back. So if we orientate this to the picture, spinous process, spinous process. One there, one there. Okay, so again, sorry that the image is flipped around. That's okay, no props, Penny. And then we've got this ligament in between. Okay, so this one here, this is your interspinous ligament. So again, this one's going to stop you from hyperflexion. So going forward, because it's joining the two spinous processes together. So as they start to open up, it will limit the amount of range of motion that you have. Okay, so that's the interspinous ligament. And then this one here, so the spinous process just there, that will relate to, on the picture, this bit just here. Okay, so you can see all of those edges. So spinous process, there's a ligament right on the end. And that's basically what we're feeling when you can feel the spinous processes when you're doing an assessment. You're actually, well, through the skin, bit of subcutaneous fat, and then you're onto the ligament. There's not much else around that region in the lumbar spine. The muscles will be either side of this area. There may be some thoracolumbar fascia, but generally the muscles are either side. So this is the supraspinous ligament, and again, this will limit hyperflexion. Okay, so we've got a number of different ligaments that will prevent hyperflexion. So you've got this supraspinous because it's superior to the spines. Okay, so the spinous processes. Interspinous, which stop the spinous processes from gapping. Ligamentum flavum, in between the lamina, stopping it from hyperflexing. And your posterior longitudinal ligament, stopping it from hyperflexing. So you've got all of those ligaments, and then the one at the back, the one to stop you going backwards, is the anterior longitudinal, which is this one. Just move me out of the way. This one just here. Okay, so vertebral body, you can just about make out ligamentum flavum in there, interspinous, supraspinous, and you can't see the posterior longitudinal because it's tucked around the back. Okay, cool. Sorry about the lack of fluidity with the videos. That's a bit annoying. Right, let's just go back to Stevie's question. So I know we can never assume, but it seems unlikely that we would damage the terminale without damaging the anterior or posterior. Sorry, meant ligamentum flavum, but think answer. Yeah, I agree. Yeah, so I'll just put that up there so it's not just me warbling on. So sorry, meant ligamentum flavum, but think the answer is the same. Yeah, I think if you're injuring, mind you, in the sacrum and the coccyx, because you don't have that gap and the lamina in between, then probably not ligamentum flavum. But if it's higher up and you do something to injure the ligamentum flavum in the lumbar spine, you will probably impact on that ligamentum terminale as well. Yeah, if it's enough to cause some significant damage to the ligamentum flavum, then you will probably stretch it enough to cause some irritation to that too. Yeah, cool. Just see if there's any more. No problem, no worries. Cool, all done. So we're on to the muscles next week, and there's quite a few around the lumbar spine. And we're going to kind of wrap around the whole body. So we might have to break it down into sections. So we're going to look at the posterior aspect and then the anterior abdominal wall as well. And the anterior abdominal wall will link up some of the inguinal ligament stuff too. So that's going to be pretty big session, that one. So we'll probably go front and then back, or back and front. We'll see how it goes. But yeah, muscles next week. We'll see you then.